Good evening, good afternoon, everybody. I'm just going to wait a couple seconds here to let everyone start joining into the webinar. We're so excited to have you on from coast to coast to coast. And as we always do at the start of our webinars, I'll ask each of you to click on that chat button in your Zoom toolbar and let us know where you're tuning in from. My name's Troy, and I'm the Director of Operations for Nurses Specialized in Wound, Ostomy, and Continence Canada. And I'm thrilled today to be joined by two amazing guest speakers for a fantastic webinar that we'll introduce just briefly. Before we get to that point, just a couple housekeeping items. Firstly, we're going to have a Q&A portion at the end of the presentation, so make sure you click on that Q&A button in your Zoom toolbar. That'll make sure we can kind of condense those and get to all of them before we finish the webinar today. It's also being recorded, so if you or your colleagues need to look at this after the fact, we will be circulating that with you as well. And just a heads up that we are going to be using a polling feature in the presentation. So keep an eye out for that. There's going to be a QR code you can scan. So do keep an eye, and that'll be awesome to get all that interactive component too. Finally, we really want to thank Coloplast today for being able to deliver this education. We sincerely appreciate it, and we know this topic is going to be really, really awesome. So without further ado, I'm going to introduce our guest speakers with us today. Firstly, we have Dr. Karen Campbell, who of course a lot of you may know already. Karen is currently an adjunct faculty for the Masters of Advanced Healthcare Practice in Wound Healing at Western University in London, Ontario. And Karen has a clinical practice experience in geriatrics, continence, and wound care, and taught the Nurse Continence Advisor, or NCA program. She's a founding board member of the International Skin Care Advisory Panel and as a consultant with EO2 and Jarlette Health Services. Karen has been involved in many Canadian, international, and RNAO best practice guidelines in wound care, and today is going to bring a wealth of experience to our continence topic. So with that, I'm also going to introduce our other panelist, Natalie Kameka, who has experience working in the community and acute care settings as a nurse specialized in wound, ostomy, and continence, and as a clinical lead at Coloplast. Natalie provides clinical expertise in ostomy and continence care. So without further ado, I'm happy to pass the mic and the slides over to Natalie. Thanks, Natalie.
Thank you very much, Troy. So our topic today is going to be on the new NSWOC Catheter Decision Aids. The learning objectives for this presentation are first to understand the basics of indwelling and intermittent catheterization, also called IC for short, review the process of developing the NSWOC Urinary Catheter Decision Aids, understand key clinical practice recommendations from the research, and we're going to utilize the urinary catheter decision aids in clinical cases. We're going to have a Slido component, so get your smartphones ready or another internet browser page pulled up. And then we'll have some time for some Q&A. And I'll give you a moment to review our disclaimer for this presentation today. So I'm going to hand the mic off to Karen Campbell to talk a little bit about what intermittent catheterization is.
And thanks, Natalie, and thanks to Coloplast and NSWOC for inviting me to do this presentation. And I really appreciate everyone joining after a long day at work and wanting to learn more about our decision aid. So intermittent catheterization, as you all know, it's a thin, flexible, hollow tube that's inserted into the urethra to drain the bladder of urine and then removed. And is typically performed 4 to 6 times a day to kind of mimic the natural filling and emptying of the bladder. And obviously, it's not a permanent part of the body. So what are the indications for intermittent catheterization? So number one here, patients with a neurogenic bladder. So people with MS, Parkinson's disease, spinal cord injury, brain injury, spina bifida, and individuals with brain and spinal cord tumors, as well as patients with bladder outlet blockage. So that would be someone with an enlarged prostate or someone that has a narrowing of their urethra. Often too, post-operatively, many of your patients will have urinary retention, and IC is often used right after that surgery just to get their bladder functioning normally again. And then finally, it's also used to dilate a narrowed urethra when you have a patient with urethral strictures. So Now, I want to really, this is a big part of what I feel strongly about. I want you all to really remember that IC is the gold standard for neurogenic lower urinary tract dysfunction. And on the right-hand side, you'll see many documents from many different groups basically talking about why this is the gold standard. And compared to indwelling catheters, IC obviously improves symptom control. They normalize bladder filling and emptying. It improves quality of life. Imagine to be walking around with a indwelling catheter and a leg bag. It absolutely reduces UTIs as well as kidney infections, reduces bladder stones. It enhances independence, supports sexual expression, and enhances confidence. So what is indwelling catheterization? So as we all know, you have a permanent catheter put in place, not permanent, but replaced every less than 30 days. And it allows a continuous flow of urine, and the distal end of the urinary catheter is a drainage channel. And if you have a two-way catheter, you have an inflation channel. And if you have a three-way catheter, you have both an inflation channel and an irrigation channel. So what are the indications for indwelling catheters? So chronic urinary retention with or without blockage when IC is not an option. I'll give you some examples. One example from my practice from when I had a continence clinic, elderly gentleman who had chronic urinary retention, lived at home with his elderly wife, and neither one of them had the actual dexterity with their hands, and they were afraid to do IC. And so the only option in this case was to put in an indwelling catheter. It's also used for management of totally immobilized patients. And when you have a critically ill patient and you need to have accurate intake and output. And finally, at palliation or end of life, it's important to use an indwelling catheter at the end of life for comfort. Short-term indwelling is less than 4 weeks, and a long-term obviously is longer than 4 weeks. So what are the challenges with indwelling catheters? So, and I feel strongly about this because I had many patients develop UTIs, and some of them went on to develop sepsis. So approximately 80% of healthcare associated UTIs are attributed to indwelling catheters. And the daily risk of a UTI with an indwelling catheter is between 3 and 7%. And if you think about prevention, an estimated 17 to 69% of catheter-associated UTIs may be preventable with implementation of evidence-based practice, which is a huge number. And these UTIs increase length of stay in hospitals, increase hospital care costs, and increase morbidity and mortality. And I can tell you stories of many patients of mine who were admitted to acute care, put in the ICU because they had sepsis secondary to a UTI. I sometimes would hear from nurses, oh, it's just a UTI, but I also have had patients die secondary to that sepsis. So this is a very serious but preventable problem. Indwelling catheters are often inserted for inappropriate indications and then left in place significantly longer than clinically necessary. And I know those of you who are on this presentation, I'm speaking to the converted, you already know that or you wouldn't be signing in. So I think we all have a role to advocate to prevent that from happening and prevent some of the complications then that go with indwelling catheters when there is an option to have intermittent CAS. So there is a lack of best practice recommendations and best practice guides in Canada for indwelling catheter use, but there is BPG for IC. And what's even more significant, when you think of all the resistant infections, by 2050, 40% of infections are projected to be resistant to antibiotics. And if you translate this to dollars, that's $7.6 billion that is spent in the healthcare system that could be used for other really important other things. And they estimate there could be 13,000 lives lost annually to resistant infection. If you add on to that, the patients of mine and other patients who die without a resistant organism, but die secondary to sepsis, the number is actually probably higher. So let's talk about the NSWOC Catheter Decision Aid. And I was fortunate to join this group partway through the process. And this is a busy slide, but if you're interested to really read more detail about what we did, this publication is in NSWOC Advance. It is a peer-reviewed document and was approved by the NSWOC board. And it was funded with an unrestricted educational grant from Coloplast. Thank you, Coloplast, but was managed under the auspices of NSWOC. So what was the methodology? I'll try to keep this simple because, of course, you get into complex methodology. We had 24 expert nurses from across Canada. Some were NSWOCs, some were NCAs, some were urology nurses, and also IPAC people were associated. And there was feedback from frontline nurses to NSWOC and to Coloplast. There was a need for a decision aid because often, you know, there would be an order for, let's say, a catheter, and the nurses would be, okay, what sort of catheter should I be using? What sort of, you know, what sort of French size, and so on and so on. And so a decision aid was developed, and although it kind of looks busy, if you actually look at the slide, Natalie will be going through it kind of slide by slide. In a sense, what it did was it took 243 articles that we reviewed in our group, and we brought it down into one page so that nurses who had to make complex decision making could make a decision as they walked into the clean supply room as to, okay, what the heck am I going to do here, without having to consult with an NCA or a physician or a urologist. So the research question that was developed for this project was, what are the clinical and individual patient factors, as well as catheter features, that guide the selection of a urinary catheter or catheter system for both intermittent and indwelling? And it focused on nurses in all practice settings, so hospital, long-term care, and community. And what we're going to be talking tonight about is very specific to the adult patient population. So the objective was to develop this decision tool for nurses to use on the front line. And there were 4 decision aids developed, 2 for indwelling, pediatric and adult, and 2 for IC, pediatric and adult. And you can access the pediatric decision aids on the NSWOCM site. But again, we're not focusing on that this evening. So a little bit about the literature search to keep it kind of easy and straightforward. There were 2 literature searches. The first one wanted to look back 2 years, and then they realized there were seminal articles leading. So a second lit search went on that had no restricted publication date. It seems like somebody has not muted their site, and we're getting some background. So if you could all mute your microphone.
It might just be me. That's my fault. Sorry about that, Karen.
Okay, Troy, that's okay. And so we came up with 243 relevant articles, and 2 members of our committee looked at all of the articles, and it was done in a very standardized and scientific way. So I'm just going to talk a little bit about clinical practice and highlights from the research. So first of all, about intermittent catheterization. So all intermittent catheters manufactured in Canada are marketed as single use only, including, you know, coated, uncoated, This means that we should not be supporting reuse of intermittent caths in your patient population because it's considered off-label. But to add to that, I've just spoken about the risk of sepsis and UTIs. And so we want to prevent any further complications that could happen. And so it's very important that we advocate and promote single use. And so the Canadian Urological Nurses Association and nursing documents, they specify single-use hydrophilic pre-lubricated catheters as first-line treatment because we know that it reduces the prevalence and incidence of UTIs. It reduces urethral trauma. It's easier to use. It improves quality of life, and it's cost effective. If we reduce UTIs and think of antibiotic use and potential stays in hospital, then you realize that it is very cost effective. So now I'm going to turn this over to Natalie.
Great. Thanks so much, Karen. So I'm going to talk a little bit about some practice or research highlights related to indwelling catheters. So I'll ask a question and take a moment to reflect on what you think the answer is. How often should you change your indwelling catheter? The answer? As per the manufacturer's instructions. So some are 15 days, some might be a little longer, but definitely anything less than 30 days is as designated by Health Canada or when clinically indicated. So at the max, 29 days, you should be leaving your indwelling in. But if there's a clinical indication like a blockage, urine's not coming out of the catheter, there's bypassing, urine is leaking around the catheter, or you need to collect a urine sample, then you need to change and use a new sterile indwelling catheter. And reducing trauma is very important, especially when it comes to indwelling catheters. Securement devices are always recommended. They can help reduce bladder neck trauma and urethral erosion, as you can see in this image here. Use of a catheter securement device would be applied either to the upper thigh in a male or female, or the abdomen in a male without traction. You want to make sure that your urine bag isn't getting too heavy. It's being emptied when it's about half full. And at minimum, urine bags should be emptied 2 to 3 times daily. This, obviously, the weight from the urine will create traction on the Foley catheter. When you are wearing a leg bag, you want to ensure that there's 2 straps. We often see sometimes 1 strap, but we do need 2 straps to adequately support and secure that leg bag. It's important as well to always use the smallest catheter required to adequately drain urine, and that size may range. And to always use the smallest balloon size, so a 3, 5, or 10 mil. The larger the balloon, the heavier it's going to be. And we want to reduce that size so we can reduce the weight and pressure on the bladder neck. And we always want to fill the balloon with sterile water. When it comes to finances, specifically when we speak to intermittent catheters, this can sometimes often come up as a concern to be adherent with single use or using the best possible catheter available to them. It's important to explore personal finances, public-private insurance policies, public-private reimbursement programs that are available. Manufacturer or distributor company support programs may also be able to help the patient navigate this extremely complex system of reimbursement. And we need to also look at that this is an issue in our country, that we don't have public funding for IC. Other countries around the world, Europe, for instance, they have full coverage for their catheters in many of those countries, and we really need to advocate for that so we can be adherent with what the best practice recommendations are saying. And so we can lean on these evidence-based tools, the Canadian best practice recommendations, the urinary catheter decision aids that we're going through with you today, to advocate for better public funding for intermittent catheters in Canada. So Coloplast does have a reimbursement specialist that can help navigate catheter coverage for your patients. So you as a clinician or the patient can call in to Hannah Cruz, and her email is here and her phone number is there. And you might be surprised to know that the majority of IC users in Canada, based on survey results of around 591 Canadians who rely on IC, have some degree of coverage. Almost 70% have some degree of coverage. So this is the Slido. You can scan the QR code here with your smartphone, or you can go to slido.com and plug in the number 7784055. If you're struggling to get this done quick enough, not to worry. As we go through the questions, this slide will reappear. So I'm going to review now the components of the adult urinary catheter decision aid for intermittent catheterization. So again, this is a snapshot of this. What I'm going to do is we're going to work through the components of this decision aid from top to bottom. So the first component of this decision aid is the importance of aseptic non-touch technique. And this involves using a sterile single-use intermittent catheter for each catheterization as indicated from Health Canada that license these medical devices. And also nurses should adhere to their organizational policies and procedures and nursing regulatory bodies. So what is aseptic non-touch technique? Essentially, you're going to start with hand washing, a gloves choice here. So sterile, non-sterile, no glove at all. So when individuals are in the home situation and they're performing IC themselves, they might not be using a glove. Depending on the medical status of this patient will also determine if you want to take extra precautions. And then the next section is your aseptic field. Are you going to be using a sterile towel? Are you going to keep the product inside the packaging? Are you going to use a clean tray but protect key parts? So key parts are anything that's going to be going inside the individual. So the majority of the length of that catheter, for instance. And then you're going to use non-touch technique. So that means inserting the catheter without touching any key parts that are going to be going into the body, because that can potentially result in contamination. And now you're introducing potential pathogens into that body. And then following the procedure, hand washing again. And this is just a friendly reminder of all the areas that sometimes get missed when we're washing our hands. So important to consider technique and when you're teaching your patients as well. So here's a quick question. You can go ahead and scan that QR code, open up a browser, go to slido.com and plug in that number. The question is, what do you believe to be the biggest challenges to recommending single-use intermittent catheters? So you can see we're starting to get a few answers coming in. So I'll give it a few more seconds here. So the ones that are being picked mostly are going to be larger. So we see, and feel free to chime in too, Karen, but we can see cost is really popping out here. Education, other words for cost like price, financial. People think they increase infection and trauma, ability. Yeah, so you've definitely go ahead.
Great job here. You've identified quite a few of the biggest challenges.
Absolutely. And we want to make sure that we address this issue because we want to be as adherent with the best practice recommendations. So if cost is a barrier, making sure that we're uncovering every stone available before we either, rule out single use or rule out hydrophilic catheters, which are the preferred catheter choice because they are shown to help reduce UTIs, urethral trauma. So if we can't get the best product available for our patient, have we looked at all the reimbursement? Have we discussed other different potential programs, insurances with our patient, or referred out? And the next component of this decision aid is size. So again, I want to reiterate, using the smallest French size that enables insertion and adequate drainage should be selected. You'll notice on the funnels that they're all color-coded to help as a quick reference check to catheter size here. The other thing I want to note is these are images or cross-sections of catheters, both 16 French. This is 100% silicone, and this is a latex coated or a latex catheter. And what I want to show you is the lumen size. So you're going to get much more drainage of urine with the same French size in a silicone catheter than you are with a latex catheter. You can see the lumen is much larger. Just the latex just has more material. So sometimes nurses are getting a larger French size, which again can increase trauma, stretch the urethra, those kinds of things. So thinking about those materials as well and how that impacts adequate drainage. And regarding catheter size, this chart was adapted from the European Association of Urological Nurses Best Practice Guidelines 2024. So these are brand new guidelines. They weren't available when we were creating this decision aid, but we're always looking to, potentially look down the road to do any updates as new evidence becomes available. So for instance, indications of when you're going to choose which side. A small adult with clear urine, no issues, a 10 French might be adequate. For adults with clear urine, no debris or grit or hematuria, 12 to 14 French is typical. If they have slightly cloudy urine, light hematuria, with or without small clots, none or mild grit and or debris, we might need a 16 French. Moderate to heavy grit and or debris or hematuria with moderate clots, then we need an 18 French, so we're looking at bigger sizes. And then adults with heavy hematuria needing flushing, 20 to 24 French. And just as a reminder, the French size is the measurement of the external diameter of a catheter. So again, although these two have the same French size, the internal diameter or internal lumen might vary. And then we get into length. So the average female urethra is about 4 centimeters long versus the average male is around 20 centimeters long, give or take. And so you can see just an image of two different intermittent catheters. We need two different sizes to accommodate either female or male anatomy. And so for females, they can use female length catheters, or they can use male length catheters if they need a longer length catheter to reach an appropriate receptacle. Like let's say a female in a wheelchair needs a longer catheter to reach into a toilet. And then for males, they are to never use female anatomy because the internal structures need to be long enough, an adequate length, a catheter to reach the bladder. And then we get into materials here. So you see hydrophilic is preferred as per the best practice recommendations. Latex is not recommended, and this is due to latex allergies and sensitivities. This is to protect our patients as well as healthcare workers who are handling these catheters and also may have sensitivities or allergies to latex. With regards to hydrophilic, the materials can vary. Polyurethane, polyvinyl chloride, silicone, thermoplastics, those are all different types of materials that may be used. Hydrophilics have their coating or hydrophilic coating already embedded onto the surface of the catheter, and that coating becomes activated with a solution, a liquid solution. You do not need to add any external lubricant to this catheter, to hydrophilic catheters. This is why this is such an advantage, and it potentially helps to reduce the risk of contamination, because you're not having to add that step for patients. As well as some patients complain about adding lubricant can be messy. So this also can make things a lot easier for them, cleaner for them, more hygienic as well. Pre-lubricated, this is when the sterile water-soluble lubricant is added to an uncoated catheter. When we say uncoated, we just basically mean there's not that coating on the surface like there is in a hydrophilic catheter. And then we have uncoated catheters. And you require a sterile single-use packet of water-soluble lubricant to be added to the surface. Okay, and I just want to note with hydrophilic again that they are the preferred choice because they can help reduce friction and trauma to that fragile urethral tissue as that catheter is gliding in and out past those tissues. And also it may reduce the risk of urinary tract infections. And eyelets, these are the little openings at the end of a catheter where urine can drain in. They can be smoothed or non-smooth. It's really important that we use smoothed eyelets. So this will be either fire polished or ultrasonically smoothened. This helps to limit urethral abrasion and erosion. You can see in this image here, when a catheter is inserted into the bladder, urine will drain into the eyelets and out of the body through the catheter, and you almost get this vacuum-like suction effect that can occur. And what can happen is the tissue, the bladder lining tissue, can get sucked into these eyelets, and if you have sharp eyelets, then that can potentially cause trauma as you're removing that catheter. So this is also why smoothed eyelets are preferred here. And then we have tips. So we have this is an image of a standard straight Nelaton tip. This is going to be your, non-complicated catheterizations. And then we have the Coude Tiemann tip here. This has a firm tip on the end. You will need to keep this tip orientated in the upright position. And each Coude catheter should have a indicator so that you know that it's orientated in the correct position on insertion and withdrawal. You can see this, for example, has a blue guide stripe here. And we often use these to navigate male anatomy, like in the case of BPH, enlarged prostates. And then we have a rounded ergothine tip. You can see pictured here. This is a flexible TB tip. It allows for easier catheterization, and it's often used for enlarged prostates, urethral strictures, or spastic pelvic floors. So a lot of the benefits of what you would get from the Tiemann tip, with the addition of a spastic pelvic floor, this has been shown to really navigate those complex curves and bends. And then we have the olive tip. This is a little rounded area at the tip of the catheter, and that's often used for urethral strictures or females that are having challenges locating the urethra. And then we might have different catheter systems to choose from. So you have your standard kind of basic intermittent catheter here. We have compact options. This allows for discretion, maybe easily carried in your purse or a pocket. There's research that actually shows that compact catheters increase quality of life for IC users. And then we have closed systems. This is when the drainage bag and intermittent catheter is pre-attached all in one. It's very useful when there's limited access to a toilet, such as, let's say, on an airplane. I've heard of people who have to cath, at their seat because they can't quite get to the airplane, to the bathroom in the airplane, or they don't have access, when they're out and about to a suitable, accessible bathroom. There should also be a urine volume indicator. And then we have the protective sleeve or grips. And this allows individuals to touch the length of the catheter, but the catheter remains sterile and protected as it's encased in this sleeve here. So excellent option for those maybe due to hand dexterity, they need to touch the length of the catheter, or for those who are learning or being trained on intermittent catheters, and the risk of contamination is high. And then we have additional considerations. So financial, we want to ensure that we're considering public, private insurance, and provincial, territorial, federal reimbursement programs. Consider patient support programs as well through manufacturers to help navigate coverage. And then environmental, we want to contact manufacturers for more details. Every company will have different, policies and programs that they're doing, and you want to consult your local waste management regarding disposal of these products. A few other practice things. We have insertion over here. We want to ensure that we're practicing that aseptic non-touch technique. We're always doing pericare as well, as that has been shown to reduce the risk of urinary tract infections. And we want to select the most appropriate catheter for our individual, document any special considerations as well, and consider topical anesthetic application prior to catheterization if the patient maybe has fear or sensitivities. With regards to urinary tract infections, there are evidence-based there's evidence-based resources available to you, like the urinary tract infection risk factors models, and urinary tract infection assessment tools that help guide you through questions to ask your patient to navigate risk factors for UTIs. And then with removing urinary catheters, we want to slowly withdraw the catheter 1 inch at a time and rotate and repositioning. As we talked about that suction that can occur, so you want to break that suction by twisting and then slowly removing. A lot of urine can sometimes pool at the bladder neck, so we want to make sure we drain all that residual urine. Residual urine can increase the risk of UTIs as well. And then troubleshooting, if catheterizations are challenging, consider a Coude or ergothon tip. And then self-management. With individuals with poor hand dexterity, consider those touchless catheters, consider insertion aids. So for instance, through the Coloplast Care Program, we offer LED leg mirrors for females to help visualize their urethra or urethral meatus easier, as well as pantlers for males. We have videos as well that show how to use these products. As well as videos on positioning and setting up for IC procedure. With urine measurement, if you do require a measurement, you can consider those compact systems as well, where the IC is attached to the urine bag, and you can get an amount of volume, or you can cath into like a specimen container. For discretion, for those that are very concerned with discretion, compact catheters are a great option for individuals as well as considering what is the packaging and having discreet disposal of these products as well. And then education. So when you are educating your patient on IC, it's really important to assess their health literacy and readiness for self-care with each clinical encounter. Now, I'm not going through the entire indwelling catheter decision aid. However, there is a lot of similarities, but 2 highlights I wanted to point out is balloon size. We recommend a 3, 5, or 10 ml balloon, as larger balloon size will put that weight on the bladder neck and urethra. Do not pre-inflate a balloon. And then we also outline the frequency of how often indwelling catheters need to be changed. So they should all be changed as per the manufacturer's instructions for use, or IFU, as per Health Canada, after less than 30 days or when clinically indicated. And always inflate your balloons with sterile water, and do so slowly, and assess for any pain or discomfort in your patient when you do so. Now we're going to get into the case scenarios, and I will let Karen introduce this case.
Hi, thanks, Natalie. So this is a case of mine from many years ago. And so I had an elderly female patient who had been in acute care and then got transferred to geriatric rehab, where I got involved. That time, I was the NP and the nurse continence advisor. And so she was diagnosed with chronic urinary retention. She was blind, but she had quite good mobility and good hand dexterity. She was very private. She was a religious person. She wanted independence in her home and discretion. She didn't want people to know that this was going on. And so, in spite of being blind, she really wanted to learn how to self-cath. The nurses at the time were like, Karen, I don't think this is possible. And I am like always a bit of a Pollyanna, and it's like anything is possible if you really want it. There were a couple of things about her. She was quite petite, and she had support for any medical devices that she needed. That was not an issue. So finances were not an issue. And now we're going to get into some questions, and they're going to be talking about what IC catheter features and so on. So what type of IC technique would you recommend for this patient? Just remember Slido.
And just for anyone who's looking through the chat there, I've put the link in the chat. If you want to click directly from that, it should bring you there too if you want to put your response in.
Yeah, so remember, she had the motivation. She had the motivation to be independent and do this on her own. Luckily, where she lived, she had her own private bedroom and her own bathroom. Yeah, good. That's a good point. Protective sleeve for learning. And Natalie, just type, jump in if you think there's anything else. Yes, a covered cath. So that could be in a pocket or a purse, and a covered cath with a sleeve. Yeah, good. You're all coming up with good points here.
For
Small
sure.
pack systems. And you're talking about an 8 French with a protective sleeve and a nub end, pre-lubricated. Yeah, hydrophilic. Yeah, you guys are doing really well. And so, we needed something that was compact. She wasn't able to actually visualize, so she had to go by feel, how she could touch her anatomy. And she wasn't used to touching her anatomy. So I had to do a lot of teaching about, here's your urethra, feel for your vagina. Initially she wanted to self-cath lying in a bed, so that she had better, feeling with her hand. I think you guys covered a whole bunch of the concepts here. So compact sleeve cath, absolutely pre-lubricated. And now I would wear sterile gloves while I was teaching her. She wanted to wear, clean gloves. She was quite good with her hygiene, so pericare wasn't a problem. Would you add anything else, Natalie, to that?
Yeah, no, I think everyone had thanks for everyone's participation. That's great. And just so you know, all your responses are anonymous. With regards to technique as well, that aseptic non-touch technique, so that you're teaching her not to touch the catheter. But I think, some great feedback. Thanks, everyone. We'll move on to the next question.
So what's the typical size that you would consider in this case?
Keeping in mind the urinary catheter decision aids that we just reviewed as well.
Right. Okay, so it looks like 10 to 12 French is the most common. And I used a 10 French with her. She was a smaller a female. And so we were able to use a 10 French. And so that seems to be the most common answer. Right, on to the next. So what length of catheter would you use in this case? Actually, obviously starting off with a female length, but after she became independent and wanted to maybe, sit in a chair and then drain her bladder into a toilet, you could consider a male length. But in her case, she wanted to self-cath on her back in her bed initially. And of course, as you get more, she gets more confident and she gets more experience. So what you start out with maybe, and 6 months later, you may, start to think a little bit different. And how can this fit into her lifestyle?
Yeah. So again, it could be male or female length is okay for someone with female anatomy.
Good. And so would you choose a hydrophilic or an uncoated IC? And remember, cost is not a factor in this case. Good. You guys all get a gold star. Hydrophilic. Yes. And I guess if you go and you order your hydrophilic and they're, back ordered or not in stock, maybe you have to, think of a pre-lubricated, but number one choice is hydrophilic.
That's right.
And what sort of eyelets would you recommend? So she's cathing 4 to 6 times a day. We want to prevent, absolutely, another gold star here, folks. Smooth eyelet.
Awesome.
Yeah,
Good.
we want to prevent trauma and UTIs.
Mm-hmm. Everyone
Great.
was listening. Awesome.
And the next one, and what catheter tip would you recommend? And there may be more than one answer to this, so think about it. Olive, absolutely. And actually, when we were working on this, my number one choice was olive, because it helps you to find the urethra. But another option, could be like a straight catheter as well, especially once the person becomes more, experienced. And Natalie, would you use an Ergofen or?
I think I would consider an Ergofen as well, potentially, just because it does have that, it's not as, I guess, bulbous as the olive tip, but it has that teardrop shape as well. That's very quite flexible and kind of help kind of meander and navigate in through the anatomy. So that could be an option as well, for sure. I think it really is, that the olive is probably a good one to start with, and then maybe once she gets used to it, or the Ergofen, and then when she gets used to it, maybe you can move to a straight.
And we just had a question pop up. Will we be covering suprapubic catheters? And no, we won't. This enabler does not cover suprapubic. So good question though. What catheter system would you recommend when she's at home? Good answers, good answers. And so I actually, to start, because she wanted to cath lying down in her bed on her back, a catheter system with a urine bag attached so we don't have urine in her bed. And I also like the suggestion in terms of protective sleeve and grip, because, we want to use like a no touch. And remember, she can feel, but she's blind. And so that would be a safety factor for her. Would you add anything to that, Natalie?
Oh, I think you covered it as well. And that systems that work at the beginning of the learning journey might change over time. And that brings us to our next question.
Right. So what would you recommend when she's outside of the home? So she's at a day meeting and she's away from her home. Yes, exactly. She may want a very compact system that she can go into the washroom and cath herself in the washroom, and then have a discreet packaging. So it's something that could be put in a purse or a pocket. And so yeah, what she would do at home could be different when she's outside of the home. And this again, it may change too as she gets more confident and more experienced and feels, I know what I'm doing here. I want to try something different.
And sometimes too, like you mentioned, that discretion, if they're, let's say a young, I'm just throwing an example, a young girl on a date with a boyfriend at his house or something like that, and they're worried about disposing their used catheter in the garbage. If you have something with discreet packaging, then it can help people feel more confident when they're dating, or out at restaurants with friends, or out and about, or at school. So these are just some of the stories that I've heard from from individuals, that why compact catheters, why discrete packaging and discrete ways of disposal is important to them.
People need to live their life. And so, how would you address financial concerns to pay for the intermittent caths in this situation? Now, in her situation, finances were not a problem. Where she lived, they would pay for any medical device that was necessary. And so we knew that there were personal reimbursement options, but I think it's good also to refer to a social worker and discharge planner so that when she went back, there was a plan already in place. And yeah, refer to industry support person, like if there wasn't funding, and Natalie, listed a link to someone that can help you with your patients.
Absolutely. There's sometimes, individuals will get denied coverage from their private insurance companies, maybe just because they didn't tick that box on those forms and paperwork. And so we do have a team that can also take the time to review paperwork with patients to, help them fill out disability tax credit forms, things like that. We know nurses are very, very busy. And so this is just something that we can assist with through Coloplast. And do you have any comments?
Yeah, and because there were a couple people that answered other to the last poll. So if you could put your maybe comments in here, I'm interested in what your thoughts are. I think we learn from each other. And so if you have any comments, just add them in. And so I can tell you that it was a successful teaching experience, in spite of the nurses going, "Oh my God, Karen, I don't know how this is going to work." And but it did work. Now I'm going to turn it over to Natalie because this is her case.
So this is a male who's using intermittent catheters. He's 45-year-old. He has a spinal cord injury. He's a paraplegic. He was injured at work and on WSIB. He has reoccurring UTIs. He was recently admitted to hospital for sepsis for UTI. Possibly he has depression. When assessing technique, he is touching the catheter on insertion. He's using an uncoated intermittent catheter and a jar of lubricant to be applied to that catheter. And he's been referred to the community NSWOC for assessment and education. So what interventions would you suggest in this case? You can select more than one as well. I'm just going to see if I can pull. Oh, good. I can pull down the options. Sorry, there's quite a few options. So actually, you should see it when you do this Slido, but yeah, I'll read through them. Review UTI risk factors and develop a plan for UTI prevention. Refer to a mental health specialist for assessment. Provide health teaching on aseptic non-touch technique. Teaching on using sterile single-use lubricant to coat an uncoated IC. Suggest to switch to a hydrophilic, suggest a sleeved catheter, suggest, the compact catheter where the bag and catheter is attached. None of the above, I don't know. Utilize the adult IC catheter decision aid to select an IC.
Can you, okay. So, really good. The first three were things that I thought about. I spent 17 years in mental health. And so I know that when someone's depressed, as you all know, because you're out there in the trenches, the hygiene may be slipped. They may not follow health teaching. But he's already had one admission for sepsis. So we need to kind of try to get the sepsis prevention and infection prevention under control. He may need to have like a mental health support worker. And Natalie and I were talking about this, and you may start out with one system with him until his depression, for example, improved. And then you may be able to do more in terms of your health teaching. But there are products on the market that can also help him. And with him being on WSIB, that there is funding. Is that correct, Nancy? Or Natalie?
Yes, it is. Yes, there's funding. So he would have, the key is getting a prescription on the frequency, and, you know, for instance, a hydrophilic catheter, 5 catheters a day. He needs a prescription to give to the WSIB claim, and then they will cover that. So just making sure they get navigated on getting that prescription ASAP to get that best product available to them. Okay, so I might have to skip over this and just get to the end of the case here. So we've talked a lot about, you know, using that best evidence to select catheters. There is definitely more opportunity through Coloplast Professional to continue your learning. There's e-learning modules available, webinars available that you can either watch that have been recorded or get notified of new webinars coming up, newsletters. So you can, if you're interested in learning more, you can check out the website or sign up here. And then Coloplast Cares, that patient support program. So it's providing, you know, product samples, having someone that your patient can speak to live, a live person on the phone, 9 a.m. to 5 p.m. Eastern Standard Time, Monday to Friday. There's different tools. There's a dedicated website. There's lots of how-to videos, which are also really helpful for nurses as well, learning how to use the different products for both people in wheelchairs, male, female anatomy, people that are standing, and pediatric and adults. And we've also recently added a really comprehensive mental health program through Teladoc Health. And what we have available now is 3 free counseling sessions with a mental health specialist done virtually that is available to your patient. So they can speak to someone for an hour 3 times to get that mental health support. We know that mental health is such an important aspect, especially for people with intimate healthcare needs. And we wanted to do more to help support these individuals in a more holistic way as well. Again, this is Hannah. This is our new reimbursement specialist for Coloplast Canada, and her contact information. And we also have this excellent booklet that's available. It's called Self-Catheterization in Everyday Life. And you can see the different topics that's covered in this. So any patients, especially those new to IC, there's lots of great tips on, you know, working, exercising, traveling, sex and intimacy for catheter users, hydration, you know, developing healthy routines, basics on urinary tract infections. That is available for your patient as well. So feel free to contact your local Coloplast rep or check us out at coloplast.ca to learn more. And we'll take a little time for some Q&A. Thank you so much.
Well, thanks for going through that. I think it was really awesome being able to use the polling there. That was so great. We do have a little bit more time if you don't mind staying on for a couple questions here. One of the questions that we had coming up was about the size of the catheter and how it might affect bypassing. Can choosing a different size help with this issue?
So Natalie, do you want to start with that, or do you want me to?
I can start with that. So with regards to bypassing, I think the common misconception is to go up in size. And that's not necessarily the solution. The solution might even be to go down in size. And if we keep increasing in size of catheter, then we can cause some issues. So understanding why they're bypassing, is there bladder spasms happening? You know, thinking about how long has that catheter been in place? You know, is there an irritant there, a stone, incrustation, those kind of issues, a urinary tract infection? Those are usually tends to be the reasons for bypassing, from my understanding, but I'll let Karen add to that as well.
Yeah, I think you have to delve deep into what is the cause. Is it spasming? And so there's medications that can be prescribed to relax, the bladder. Is it a UTI? I mean, that's a test that can be done quite quickly. So you need to figure out the cause of the spasming. And then, as Natalie said, bigger isn't always better. And in fact, do you need to go to a silicone catheter that has a larger internal lumen, for example, and go down in size? And sometimes it's a bit, it is teamwork. So get your physician involved. Try, going down in size, try, silicone. But I think typically what happens is people go up in size, and that can actually sometimes make it worse, and you can cause then more trauma.
Yeah, agreed.
Thank you for touching on that. We got some great other questions that are coming out here. Kirsten is just asking, how about for those that find that it easily gets blocked?
Okay. And you're talking about an indwelling catheter.
Yeah.
I'm assuming. Yeah. Okay. So I'll start with that. Then I'm going to pass it over to Natalie. So again, like what is going on in terms of the blockage? Are they hydrated enough? Again, it's digging to the root of what's causing the blockage. Are there clots? Is it debris? And you may actually, if it gets quite complicated, they may have to see a urologist. Like, we may need a little bit more in-depth assessment, and not going right to irrigation, which has kind of come out of favor a little bit. But I know, 30 years ago, people went right to bladder irrigation. But I'm always looking at what is the root cause of this. And, are they taking, I had patients taking 2,000 milligrams of vitamin C a day, and then, having, blockages because of that. Natalie, what would you add to that?
Yeah, that's interesting. Yeah, I think you touched on most of the main points. Just also, sometimes things can get kinked. So it's, if you're flushing something that's kinked, it may not even, the fluid might not go in. And then length in that the length of time that catheter has been in place, it might be too long for that individual. They might be prone to incrustations, they might be prone to stones and things like that, and that could be resulting in the blockage. So I think that, again, like Karen said, just is evaluating, all these things, and maybe they do need more assessment to see what's going on, and are things draining okay, and if they're not, they might need those urodynamic assessments as well, referrals.
Perfect. Well, on that note too, we had another question about when to refer potentially here, and someone was just asking here, let me just pull it up again. If a client is burning pain while the catheter is in place, can a new catheter be inserted, or does the client need to be referred for an assessment for possible infection? How do you approach situations like that?
Number one, I think, do they have an allergy? Or do they have an allergy or sensitivity to the material? Number two, yes, you could actually rule out a UTI, absolutely. But was there trauma with the insertion? And so that's causing the burning. Are they using a hydrophilic catheter? Is the catheter size too large? So as you're inserting it and it's in there, now you've got all these little areas of trauma that can be quite painful.
Yeah, I agree. And I was going to say, do they have a securement device in place as well? Maybe they're an active person and they're getting up and they're walking around. Maybe they're not emptying their urine bag frequently enough, and that weight is causing traction. So thinking about how that Foley catheter is being supported, because you think about these tubes are in a very sensitive area, and if they're dangling around, if they're potentially getting pulled on, if they're attached to something with a lot of weight to it, then that could be a source of trauma. And then with regards to, yes, could it be a UTI? Potentially. We know that burning and pain is one of the potential signs and symptoms, but to adequately diagnose UTIs, we need to look at the symptoms as well as a urinalysis to confirm diagnosis as well. So not just, it's not one or the other, it's really looking at that. Those two items are really important to look at them together.
Because we do not treat asymptomatic bacteriuria. That is not something we treat. It can create resistant organisms, and you've already heard us talking about that. So good points, Natalie.
We had a few people who were asking about inflating the balloon prior to the insertion of an indwelling. So is it recommended, or is it true that we shouldn't inflate the balloon of an indwelling catheter before insertion to maintain its integrity? Do you want to just talk about that for a moment?
No, you should not inflate the balloon. Absolutely.
And that's also in our decision aid as well. I think we outlined do not pre-inflate the balloon as well.
Okay, and that also touches on the question here. If your catheter balloon says 5 cc, says 5 cc, should I inflate it with exactly 5 cc's of sterile water, or is there a need to add more for priming? They were taught that this was the listed amount that they should add in. So can you just clarify that?
Natalie, do you want to answer that?
Yeah, my understanding would be if it says 5 cc, just insert 5 cc. That's it. It's just a very tiny, like we even kind of showed you that cross section. It's very tiny little channel. So yeah, it's not like it's going to take a lot of volume of water in that teeny tiny little channel that makes its way up to the balloon. So do you want to add to that, Karen?
No, that's a really good question, because I know I would be asked all the time, if it's a 5 cc balloon, should I put 10 cc's in to allow for priming? But no. And you don't want to overinflate the balloon because you have a risk of it rupturing. And now we have a foreign body in the bladder, which could be a major problem.
Yeah.
Thank you. Okay, we've got a few more here. I'm just seeing we're going a little bit over here, so I'll do a couple more before we end it. And again, there were quite a few contacts there to get in touch with Coloplast. If you did have more questions about product or about some of the guides or anything else there, I'm sure we can get you in touch with them. Or if you send an email to office@nswoc.ca, we can get you in contact too. Let's go to this question that was coming up as well here. More of a case-based one here. In long-term care, I have a patient with dementia who resists having an indwelling catheter, and when we try intermittent catheterization, they become aggressive. So how do you handle a situation like that in long-term care?
Okay, I'm going to answer this one because this is something that I deal with in my actual practice. And we have all had, patients with dementia that will pull out IVs and catheters. And then you're left with how do we deal with this, and if they become aggressive. So number one, you need to link in with the physician and get them referred to potentially a geri psych ASAP to better manage their behaviors. You have behavioral support teams in long-term care, at least they do in Ontario. So every home has a behavioral support specialist that help with disruptive behaviors. And if they're not in-house, then it's someone that you can refer to. You also need to keep the family involved and the decision makers involved for this person, because it is a risky behavior, but at the same time, you can't have a patient pulling out a Foley catheter every hour and causing more trauma and bleeding. And yes, I've had nurses who've been assaulted as they've tried to do IC. They may require medication. They may require, a specialist behavioral support person. Sometimes in the cases that I've been involved with, these people have been abused when they were younger, and then they're fighting back when they're older and their brain is not working properly, and so they see this as an assault on them, and they fight back. Hence why you need the behavioral support, and you may need geriatric psych to come in to really review all their medications, because, you know, if they're having hydronephrosis and back up into their kidneys, family really need to be aware of the seriousness of this, and decisions have to be made. I don't know if anyone else would add to this, but this is an issue that I have seen and have dealt with on several occasions.
Well, thank you for touching on that. I know we've got lots of other questions here, and I think if we can get in touch with Natalie's put her email in the chat there. We are going to be following up from this webinar with a certificate of attendance. That's going to be coming from nswoc@gmail.com. Don't forget. So if you're anyone who was having issues receiving your certificate, do take a look in your junk mailbox for that. But do get in contact with us from that email if you'd like, or with Natalie there too, and we'll make sure we can get you in touch for some of these questions here. I want to thank both of you so much. You can tell by the engagement, the interaction on the polls, all these questions. It's such a great topic and very important that we're able to go through the guides here. So thank you so much for touching on these cases, for sharing your expertise, and then we hope we can see you online again for another webinar.
Yeah,
Awesome.
thanks so much, Troy. Thanks, Karen.
Thanks
Everyone.
And have a great night.
Yeah,
Bye now.
it was fun. Bye, everyone. Have a good
Bye.
night.